The following is the presentation and audio recording of an online presentation by Dr. Robert Brooker from Fort Lauderdale, Florida on April 11, 2018. The presentation was to a selected group of clinicians from the following institutions in St. Petersburg, Russia: the Institute of Medical Education, Almazov National Medical Research Center, the Nikiforov Russian Center of Emergency and Radiation Medicine, the Northwestern State Medical University, St. Petersburg Children's Hospital No. 1, and St. Petersburg City Hospital No. 26. Please note, Dr. Brooker is a car racing enthusiast and uses images of cars as visual cues to pause for translations and questions. In most cases, these have been edited out unless accompanied by relevant audio content. As specified in the US FDA 510K clearance, the non-invasive Foresight Elite Absolute Tissue Oximeter is intended for use as an adjunct monitor of absolute regional hemoglobin oxygen saturation of blood under the sensors in individuals at risk for reduced blood flow or no flow ischemic states. In this video, the applications and descriptions of the use of the information provided by the monitor in a clinical setting represent the medical opinion of Dr. Brooker.
Great. All right. Well, let's start then. So the point of today's presentation is basically to go over the value of an accurate cerebral oximeter, and because in reviewing the attendees who are at your institution, most of you have experience with cerebral oximetry, and I'm going to try to convince you today as to why it's a good idea to try to use a oximeter that has a high degree of accuracy. So a little background about myself: I'm the chief of cardiac anesthesia at a large quaternary hospital in Hollywood, Florida. I'm also an associate clinical professor at Wake Forest University. I've been doing anesthesia for quite a while and using cerebral oximetry for quite a while. I have about 9 years experience with the CASMed Foresight device, and also enjoy working on cars and surfing, which is one of the reasons I'm in South Florida. So to get right to the heart of the matter, why are you interested in using technologies like cerebral oximetry, and why is accuracy important? The reason that oximetry is gaining traction in clinical practice, this is all information all of you are aware of, but desaturations do happen, and they've been correlated with worse postoperative outcome. Furthermore, if saturations occur, it's now been shown that you can intervene using the algorithms that are suggested by the oximetry community to reverse them, and that if you do reverse them, that you can improve outcome. So the key thing for us here relative to cardiac surgery is the issue about accuracy. If you're going to use the device to govern what you do in the operating room, you need a device that is going to provide accurate information, and we'll talk a little bit more about that. So in terms of why do we apply cerebral oximetry to cardiac surgery? Well, the fundamental reason is that despite continued advances, as everybody in the audience knows, neurologic injury is still a problem for patients having heart surgery. And as we move forward in cardiac surgery, the difficulty that we face with patients just gets worse. Patients have increasing age that we see in the operating room, and the problems they're bringing to the operating room become more complex, it seems like, almost on a daily basis. So when we look at what happens to patients during surgery, they do have strokes, and in a community practice, a lot of times people underappreciate the degree of neurologic injury that's actually occurring because we don't specifically look for it. And in addition to a gross stroke, there are other things that happen to patients during cardiac surgery that are also problem. A big one is this neurocognitive dysfunction, which can occur in up to 30% of patients after surgery. And this, as everybody knows, is a defect in the higher neurointegrative function of the brain. And in a lot of patients, this improves, but in a lot of patients, it doesn't. And then you have diffuse brain injury, which is a spectrum including delirium, which can occur in patients. So this is a problem that we see in our patients that we haven't really solved yet. And relative to the underreporting, this is an interesting statistic. If you look at TAVR, for example, the average gross stroke rate that most people are quoted is 1 to 3% with doing a TAVR. But if you do MRIs on their brains after the TAVR, and this is data from a sub-study from partners, you'll find a very high incidence of evidence of neurologic injury, of embolic stroke. So it's really a problem that we still deal with every day. And again, by review, the mechanisms for neurologic injury are multiple. We have cerebral embolization. We have issues of inadequate cerebral oxygen delivery to the brain, which is what we're going to focus on relative to the value of the oximeter. You have secondary injury created by hyperthermia or hyperglycemia at a time brain injury occurs. And then you also have cerebral inflammation, which can be triggered by contact elevation, activation of the blood rather, when blood goes to the bypass pump, and also from effects of transfusion. So we have all these different areas of injury to the brain that can occur. So at our institution, we utilize a multimodal approach to try to maximize people's functional state when they have surgery. Okay, and that includes use of echocardiography. And we're using the echo to scan the aorta for atherosclerotic plaquing and to make sure that if we do open cardiac procedures, we've adequately de-aired the heart. We pay scrupulous attention to avoiding secondary injury by monitoring brain temperature and glucose during the operations to avoid over-rewarming and hyperglycemia should brain injury occur. We use cerebral oximetry, and this is where the importance of having an accurate device comes in, because we will use the cerebral oximeter as our way to ensure that we're delivering adequate oxygen delivery to the brain. And it also, as we'll talk about later, you can use it to help you trying to make a decision of whether the patient needs a transfusion to increase their oxygen carrying capacity. So we use the echocardiography, again, then to influence what surgical technique we're going to employ. For example, if the patient has a highly diseased ascending aorta that wasn't appreciated at the time of evaluation, the surgeons will actually change their technique to stay away from those areas. And finally, we have a routine use of antifibrinolytics. And we have preset protocols for how these are used, and these will help to reduce inflammation, the inflammatory response of the blood to the bypass circuit, and will help decrease bleeding, which can lower transfusion rates. So this is our multimodal approach to optimizing functional status after cardiac surgery. So relative to the big picture with heart surgery, what are our goals? Well, our goals are pretty straightforward. We want to fix the patient's cardiovascular problem, but we want them to wake up and be functional. We want their brains to work and for them to go back to whatever they were doing before they had their surgery. Because if you do surgery and you fix their brain or you fix their heart but you injure the brain, you've done them a disservice. And you've actually created a problem, because now you got a patient whose heart is fixed, but their brain doesn't work, and that can be a big burden on the family and society. So in accomplishing these goals, what do we need to know? Well, during the course of surgery, we need to know that the brain is receiving an adequate supply of oxygen. And this is a key element. That's going to be dependent on as everybody knows, the oxygen delivery to the brain. We want to make sure that we're not actively harming the brain. And to do that, we have to pay careful attention to glucose control, avoiding over-rewarming of the brain, and minimizing the risk of embolization and transfusion. So this is kind of from a 30,000-foot perspective, the things that we're doing to improve neurologic outcome after cardiac surgery. All right, so to further go into detail relative to the question of the oximeter, this is all review for your audience, but it's important to think about it because it, again, supports the idea of using an oximeter and highlights the idea of using one that has good accuracy. So relative to oxygen delivery to the brain, there are two primary drivers. You've got the cerebral perfusion pressure, and then you've got the whole issue of oxygen delivery to the brain. And the oxygen delivery obviously is going to be governed by cardiac output and your oxygen content. So these are the core components that are going to determine during your operation oxygen delivery to the brain. So to highlight the real core issue here, I'm going to present a case. So we have a 84-year-old patient. This was one of my cases recently. He's going to have a 3-vessel bypass. He's got the typical past medical history, hypertension, diabetes. He's had a stroke, and he's got some neurocognitive dysfunction already. He's on typical medications here in the United States, beta blocker, ACE inhibitor. So the question then becomes, when I go in the operating room, for this particular patient, what is the safe mean arterial pressure for this guy when we go on bypass? What is the safe minimum flow rate? And what's the safe minimum hematocrit? And these are questions that as cardiac anesthesiologists and intensivists, we deal with this every day. And whether you make an active choice about what your flow rates, pressures, and minimum hematocrit is going to be, or whether you allow, you have the surgeons or perfusionists decide, somebody is making a decision about these variables. So given that, then you have two anesthetic plans you can use. You got plan A, which is really what I used to do before oximetry. And plan A is I would rely on perfusion flow rates and pressures that were established in prior surgical trials, and or were protocols that were established at the institution where I was working. It was not individualized, and so basically you were taking an educated guess. Is that pump flow rate on bypass high enough? Is the perfusion pressure high enough? And is the hematocrit adequate? And you really didn't know whether your guess was going to be good or not. Well, what we do now is use plan B. And this is where having an accurate cerebral oximeter is so valuable to us, because instead of guessing or using historical controls, we're going to use a device which can actually tell us that with reasonable accuracy that the brain is getting adequate oxygen delivery. Everybody in the room knows these equations already. So again, in terms of the key questions relative to the oximeter and cardiac surgery, these are the key questions. When you're on bypass, is the blood pressure adequate? We always have the hemodilution that occurs. So you're on pump, is the hemoglobin level high enough? Is the pump flow rate high enough? And then off pump, are you hyperventilating or adequately ventilating? And these are all questions that one way or the other we have to deal with in every case. So prior to having an accurate cerebral oximeter, again, we really didn't know what the right answers were. And, at most we were taking an educated guess based on institutional preference or historical data. And as we already talked about, the population of patients we're dealing with today are not the same as patients that were studied even 10 years ago. They're older and they're sicker and they have more comorbidity. All right, so getting back to the cerebral oximetry then, how then does an accurate cerebral oximeter help you during cardiac surgery? And this is really the nuts and bolts of what we're talking about today. So again, we've talked about the fact that this is the information you would like to know the answer to during surgery. Is the brain getting enough oxygen delivery? And that's going to depend on the cerebral perfusion pressure and the oxygen delivery to the brain. And is there something going on during the operation that you might not be aware of? A problem that is going to be not good for the patient, but not readily apparent. We had a case, for example, of a retroperitoneal bleed during surgery, and the thing that clued us into the problem was the oximeter was showing a progressive desaturation, and but everything else appeared normal. And then the patient started to drop their hemoglobin. So the oximeter cluing us in that things were not quite right really helped us move forward with figuring out what the problem is. So therein lies the value of an accurate cerebral oximeter. You now have a device that can tell you the perfusion pressure is high enough, the flow rate on bypass is high enough, and your hemoglobin level is high enough to keep the brain in a place where it's getting enough oxygen delivery. And if you're not using an oximeter or using an oximeter that is not very accurate, again, you just don't know whether your guess is going to be good for that particular patient. So this is an example of a case showing how we use the cerebral oximeter to help us deal with these issues. So this is an 85-year-old patient who came for CABG. She's got a past history of hypertension and a significant right carotid stenosis, which she was asymptomatic from. So after induction of general anesthesia, we put the oximeter on, and with the CASMed device, if you're generally over 60, that indicates that the brain is getting adequate cerebral oxygen delivery. So everything looked good at the start. We go on bypass, and the oximeter on the right side drops below 60. So this is a warning flag that one of the variables we talked about needs to be improved because the brain is not getting enough oxygen delivery. So what did we do? We increased our pump flow rate, and we increased our mean arterial pressure. And we had a improvement of the saturation back to the 60 level. We go on with the case, and during rewarming, the sats dropped again. And this time we allowed the CO2 to come up, and the saturations recovered. So we're directly using the cerebral oximeter to help us manage all the variables that influence cerebral blood flow during the bypass run. So the operation was completed, and the patient recovered, fortunately, with no deficits. So that's an example of, from a practical standpoint, of how we use the device. This is another case example. This shows the trends on the actual monitor screen in the OR. This is where we started. We had the baseline saturations here. We went on bypass, and you can see that there was a pretty significant, pretty significant desaturation upon going on pump. So that tells us that we have a problem, that either our perfusion pressure is not high enough or our flow rates aren't high enough, or we have the anemia that's occurred because you've gone on bypass needs to be treated. So we went through our normal algorithm, which I'm sure all of you are aware. We raised the perfusion pressure, we increased our flow rate, and we start seeing a recovery of the saturation. So we know we're moving in the right direction. And then shortly thereafter, those interventions have got us back above 60. We move forward with the case, we start rewarming, and we see this all the time. And it's not surprising. As you rewarm the patient, your oxygen consumption is going to go up. And sure enough, we start to see another desaturation. So we go through the same algorithm and we treat that. You can see that we've reversed the desaturation and returned the brain to a spot where it's getting adequate oxygen delivery. So these are two examples of how practically we use the oximeter and why the issue of precision is so important. Because if the device is just giving you a trend or is moving erratically, you're not going to believe the information it's giving you, and therefore you're not going to use that information to help you manage the patient. Talk about oximetry and autoregulation in a little more detail. And again, this is going to be a review for everybody in the audience because they deal with this every day, but it helps point out again how the oximeter can help manage these issues. So everybody knows what cerebral autoregulation is. The key thing from this slide I want to remind everybody is that patients do not come to the hospital with a tag that says my lower limit of autoregulation is 70 or 60. And that's an important issue. Again, by review, we all know here's the cerebral autoregulation curve, that it's a complex system. And there are multiple variables that influence the ability of the brain to maintain a constant oxygen delivery over a wide range of pressures. But it's actually a very elegant system. Again, by review, it's a system that is locally controlled in the brain itself and driven by issues related to oxygen consumption by the neural tissue. So it's helpful to revisit the cerebral autoregulation curve a little bit just to point out one thing for everybody here, because we're all very familiar with this, and that's this, again, this point in the curve here. This is the lower limit of cerebral autoregulation, and as everybody here knows, if you drop below that, the brain cannot vasodilate anymore to increase oxygen delivery. So you start to fall off the curve, and the brain will ultimately end up being ischemic. So during cardiac surgery generally, or for patients having other operations, you want to maintain a mean arterial pressure that is above this point. And again, a key thing I want to remind everybody is that every patient's number here is not 50. It's variable. And the patients do not come to the hospital, unfortunately, with a number on their chart saying, my lower limit of autoregulation is 60, or my lower limit of autoregulation is 100. You simply don't know what that number is. And the reason for that is it all depends on the pathophysiology of the individual patient. And individual patients all are variable. So if you take 100 people, these numbers are going to be all over the place as to where the safe lower limit of mean arterial pressure is for that person. And again, remember that during cardiac surgery, whether it's on bypass or off bypass, you have to decide what that number is. And because, or somebody in the room is deciding what that number is because you're managing the patient. You're controlling the blood pressure. You're controlling the cardiac output. And you or someone on your team is controlling what the hemoglobin level is. So these are all variables that one way or the other we have to make a decision about with every case. And again, the important point is the variability here and not being able to reliably predict what that number is. So again, getting back to the point that I think is really important here is why do we care about the cerebral autoregulation curve? And again, the thing to reinforce is that that number, that magic number, is going to vary from patient to patient. And you're never really going to know what that number is in an individual case. So a good example of that is a recent study by a friend of mine, Charles Hogue, who's a real expert in cerebral physiology and cardiac anesthesia. So what they did in this trial was they wanted to measure what the lower limit of autoregulation was in the patients coming for cardiac surgery. And what they found was very interesting. The first thing was they found a wide variation in the lower limit of autoregulation, which was no surprise. But what was a surprise is that they found a very poor correlation in what that number was and patients' risk factors, because many clinicians, myself included, had thought, well, if the guy comes in and they're chronically hypertensive and their mean arterial pressure is really high before surgery, their autoregulation number was going to be shifted way to the right. And that makes perfect sense. But the reality is that that correlation really didn't exist, and it was much more random. Another thing they found was looking at the cerebral oximeter, comparing that to transcranial Doppler. They found that when the mean arterial pressure dropped below the lower limit of autoregulation in these patients, that the cerebral oximeter showed desaturation. So it demonstrated the value of using cerebral oximetry to help show you that you were not adequately perfusing the brain. So this is a graph from that study showing the range of mean arterial pressures at the lower limit of cerebral autoregulation. You can see is a wide distribution, some very high and some even lower than the typical 50 you see published. This is no surprise to anybody. We all knew that. What was a surprise was this. If you looked at the patients, men and women, and these were the groups that had lower limit of cerebral autoregulation numbers in these categories, and you compared patients who had comorbidities, meaning diabetes, hypertension, prior stroke, all the things that you would think would make them need a higher perfusion pressure, and you compared them to patients who did not have any of those comorbidities, there was no difference in the number of people at these particular spots in on the pressure spectrum. So what this tells us is that it's very hard to predict what that lower limit of autoregulation is. So it's very hard to know what the magic blood pressure number is on bypass. So getting back to why we're all here today, how does an accurate cerebral oximeter help with this? Well, it's very simple. If you're not using a full montage EEG, or you're not measuring a cerebral blood velocity with transcranial Doppler, you really don't know that your patient's blood pressure or cerebral perfusion pressure is adequate. You're doing the old-fashioned way, which was basically taking a guess. And Again, if you do take a guess, an educated guess, you're likely to not be accurate because it's highly variable. So my point to you is very simple, is that if you use an accurate cerebral oximeter, you turn an educated guess into something that's a little more accurate. And if I was the patient having heart surgery and I'm going on bypass, I would want the physician to use something that's actually giving them real data that my brain is getting enough oxygen delivery. So that brings us to the issue of the accuracy. Some of the devices that you can use that provide cerebral oximetric data are really not reliable enough to use the way I've described. We had one of the other device companies in the hospital before we switched to the CASMED device, and the numbers didn't correlate with clinical reality. So there was a very low level of confidence. But if you start using the CASMED device, you'll find that when you lower the pump flow rate, for example, to cross clamp or to take the clamp on or off, you'll see the oximeter dropping at a time when you would expect it to drop. So it really has provided us with a valuable tool to help manage our patients. So going back to the case that we discussed earlier, using the cerebral oximeter that we currently have, we make direct changes based on that data during the course of the bypass run. And those changes are going to be follow the algorithm that everybody is well aware of, that includes raising mean arterial pressure, raising cardiac output, allowing CO2 to go up, and then also to look for other things like obstruction to venous return with the venous cannula and so on. So we use it on a day-to-day basis in that way, and we have good neurologic outcome in our patients. So once you start to use the oximeter, and as for those of you who are using it already there, which I know a significant number are, you see patterns that develop relative to what you're doing. And this is an example of a patient having a circulatory arrest, but for example, as you're cooling, you see the cerebral saturations go up, which you would expect. And then when you start circ arrest, you get a progressive desaturation. And those patterns are important because in cases where things are going wrong, you see a different pattern. This is an example of a patient who is going to be, who is going to be undergoing circ arrest. So they start the cooling on bypass, and instead of seeing an increase in the cerebral sat, they see a decrease. So this was a warning flag that something wasn't quite right. And what was happening is they had entrainment of air in the cannula and were having continuous air embolization to the brain. So if you weren't using an oximeter at all, or you were using an oximeter that you really didn't believe, you wouldn't necessarily be clued in there was any problem. And if they hadn't intervened, a patient that had a kind of a rocky course, he eventually recovered, but they wouldn't have known about it at all, and he potentially may not have recovered. So the point is that the cerebral oximeter can really help you if you have one that is accurate. Feel confident that the brain is being well perfused, and if the brain is being well perfused, the kidney and the gut and the rest of the body are probably in good shape as well. And this is just an example of the information from the Foresight device, where it shows the range of acceptability and the interventions that you're going to do if the patient desaturates, which we've highlighted in those cases I went over. So it really does work, and that's how we use it every day. So now that we've discussed the basis that we use the oximeter to help us with management of bypass in terms of cerebral perfusion pressure, cerebral blood flow, I'm going to talk a little bit about the oximeter and blood management, because ultimately, as again everybody here knows, an important component of oxygen delivery to the brain is oxygen content of the blood. And unfortunately, our patients here often present with issues that create anemia. And so a question we're always facing is the hemoglobin adequate, or is it low enough that we need to give blood? So just to say a few words about the issue of transfusion, you have to kind of break it down into why do you want to give blood, and also why would you want to avoid giving blood. So in terms of reasons to transfuse, it's pretty simple. The only reason to transfuse patients with packed cells, red blood cells, or whole blood is you have inadequate oxygen delivery to the tissues. And that can be for whatever reason, either low cardiac output or exsanguination, but this fundamentally is the primary goal, is to restore oxygen delivery. So reasons on the other side, if we talk about reasons to avoid transfusion, there are all kinds. That transfusion of blood is associated with all these bad things: increased mortality, increased rates of renal failure, increased rates of infection, including sternal infection, increased higher levels of brain dysfunction after surgery, a decrement in lung function, and also the problem of transfusion reactions and infections from the blood. So you have a lot of reasons not to transfuse patients. And again, in the United States, we're slowly becoming much more process oriented, with the bottom line being the cost and how well patients do. So when you talk about transfusion, it's going to affect both of those elements, because think about blood transfusion as a liquid organ transplant. You know, one of my mentors used to say, a transfusion is only good if you really need it. Otherwise, it's not really the greatest thing for you. And that bears out. So if you reduce transfusion rates, you're going to reduce blood bank costs and hospital costs, but you're going to have better patient outcomes. And all of that is driven by consequences of transfusion that we just talked about. A nice example that highlights the negative effect of transfusion is this study from ANA a few years ago, where they looked at the hazard ratio for decreased survival after cardiac surgery. And if you look at the hazard ratio and compare it to transfusion rates, even 1 or 2 units of blood significantly increased your chances of not surviving after cardiac surgery. Just 1 or 2 units. So it's a real association. And so in the United States, there's a real drive. In fact, one of our quality indicators that we report on is how many units of blood patients get. Because the more you transfuse, that is directly correlates with a reduction in the quality rating you get for your program. And again, this is the reason. Just 1 or 2 units of blood correlates with a 16% increase in the chances of you not surviving after cardiac surgery. So these are curves demonstrating that from that study. This is the black line is survival rates of patients who didn't get transfused. The red line is patients who just got 1 or 2 units. So in our program, we try to figure out where the fine line is between transfusion and non-transfusion. And there are a lot of guidelines here in the United States that go over the issues related to transfusion and provide guidance in terms of how you can reduce blood utilization. But a key element in this is that at the end of the day, there is a point below which it's unsafe for anemia. And so the question is, how do you know what that minimum level is? All right, so let's talk a little bit about how we manage our blood transfusions at our institution here. So we have a comprehensive blood transfusion program, but a key point related to what we're talking about this morning is the oximeter can play a role in that. And again, the goal is to try to get the sweet spot where we can not transfuse the patients that are going to do okay without the blood and transfuse the ones that really need a transfusion. And an accurate cerebral oximeter can help you make that decision. So in terms of the nuts and bolts of our transfusion protocol, we have a preoperative anemia clinic, because one of the biggest drivers of intraoperative transfusion is preoperative anemia. So if we can get the patients seen early and identify patients with small or reduced red cell mass and get them on some iron, and if they have a chronic GI bleed, deal with that, then that's going to pay dividends on the other end. Another important part is that, along with the pre-op anemia clinic, is having everybody, and this is not easy, but having everybody involved with management of the patients be part of the blood management team. So they all are aware of what you're doing and they buy into it. The next part is to optimize stopping anticoagulants. And as everybody there deals with it on a daily basis, every other day the cardiologists come up with a new antiplatelet agent or a new blood thinner. So it's important to work with them to get these things stopped at a time that's safe, so that you don't deal with that intraoperatively. In the operating room, we have a protocol that minimizes crystalloid administration and has specific recommendations about when to use colloid to try to reduce the hemodilution that occurs in the patients. Along that line, we try to tailor our bypass circuits to the proper size to the patient's BSA to minimize the circuit volume. That's going to minimize your pump prime. We also will do retrograde arterial priming, where we allow on the venous side some of the crystalloid prime to be displaced by the patient's blood volume before we go on bypass, to also work toward minimizing hemodilution. We routinely use antifibrinolytics and have a protocol so that everybody's doing the same thing to ensure you get whether you use TXA or Amicar, you're getting a serum level that is properly inhibiting thrombolysis. In patients who have an adequate red blood cell mass, we'll do isovolemic hemodilution and take 400 or 500 ml whole blood off in a citrated bag, and then hold that till the bypass run is finished, and then you can give that blood back. This is a very underutilized tool that everybody can do, and it's very easy. And if the patient drops below our transfusion threshold on bypass, we give the blood back. I mean, it's a situation where you don't lose. So ideally, you keep this blood, which is whole blood, isolated from the bypass pump, so the platelets and everything in there works optimally, and give it back after the surgery is completed. And then we employ point-of-care testing in the operating room to run tags, and we do heparin monitoring to help us tailor our heparin dosing and make sure we're adequately reversed. And finally, we use the cerebral oximeter when we're on bypass and during the case to help us be reassured that the transfusion trigger we're using is not too low. For example, if the patient goes on bypass and their hemoglobin is 8 and the cerebral oximeter starts to show desaturation, and you can't improve that by increasing the perfusion pressure, increasing the pump flow rate, you check to make sure venous return is optimal. At the end of the day, it may be that that hemoglobin of 8 or 7, or whatever their level is at that point, is not high enough. And that will prompt us to give a unit of blood. Conversely, as in this example, we use it to not transfuse. So this is a case from a few weeks ago, actually a couple months ago. Fairly young lady coming for cardiac surgery, normal kidney and carotid studies, good EF. She starts out, as a lot of our patients do, a little on the anemic side. And she's a small patient, so we go off to sleep. Oximetry is good. We go on bypass, and her hemoglobin level drops to 7. And with that hemoglobin, we're at our transfusion threshold, but the pump volume is good, and our flow rates are adequate. So the question is then, what do? You know, if the patient is hovering right at the transfusion threshold, should you give the 1 unit or not? You know, it's a question we deal with every day. So what we do at our institution is we will monitor the patient's cerebral oximetry level. And again, if the saturation drops and we can't return it to a safe level by the other interventions, then we'll resort to transfusion. But on the other hand, if the oximeter remains in the normal range, we feel comfortable finishing the case. And in this particular instance, the patient woke up and did fine after surgery. So we avoided giving that 1 or 2 units, which helps the patient avoid having postoperative complications. All right, so the question is, what level of accuracy does the device have during heating and cooling? Is that correct? Okay, well, the oximeters that are on the market, the device, the Foresight device, has the best precision rating, and relative to the other equipment is the most accurate. So that degree of accuracy is about as good as it's going to be using a cerebral oximeter with today's technology. And whether you're cooling or heating, those changes in the patient's physiologic condition don't really change the accuracy of the device. So is it perfect? No, there's no perfect device, but it's the best one relative to the issue of accuracy that's on the market, and that's why we use it.
Do you usually use hypothermia during cardiopulmonary bypass?
Yeah, our current practice is mild hypothermia, so they usually allow the patient to drift to about 34 degrees, and during our typical bypass cases. So there is a rewarming period, and here again is an important point that it's hard to put a temperature probe in the brain. You know, most patients don't like to have a hole in their head drilled. So we use a nasopharyngeal temperature probe, but we try to position it at the cribriform plate through the nose. And That's our surrogate for brain temperature. So we have strict rules for the perfusionist to watch that temperature relative to the bladder and limit the temperature of the blood going into the patient so that that temperature doesn't exceed 37 degrees at all during the rewarming process. And we apply that to all the cases we do, because obviously circulatory arrest cases, depending on whether we're going to do antegrade cerebral perfusion or other brain preservation processes, will dictate how low we go. But we'll go down to 18 degrees sometimes. So the point is that even if you just drift like we do, you still have to go through a rewarming phase. And during that phase, you put the brain at risk of injury from hyperthermia if you're not carefully monitoring that temperature. And there again, let's say you do a circ arrest case and you're going to do antegrade cerebral perfusion, and you're going to do that through an axillary catheter, right? And perfuse up the right internal carotid. The cerebral oximeter will show you if you're getting good contralateral flow. So in addition to the day-to-day maintenance or management issues of, is the perfusion pressure high enough, is the flow rate high enough, etc., when you do more complex things, the oximeter really provides a lot of help, because it gives you an extra degree of information to know that whatever you're doing to keep the brain preserved, you're doing it optimally. Okay, so let's keep going with the presentation then. So back to the issue of the transfusion program, and if you just decide to employ a transfusion program, does it work? So I'll show you the experience we had at our institution. So shortly after I arrived in South Florida from my previous academic job, we had a high utilization of blood. So for every case we were doing, we were almost giving 2 units of blood, which was above the regional average and was a problem. So we developed that program I showed you and instituted it in 2007. And we also, at this point, changed the oximeter we were using. We were using one of the competitors' oximeters here when I arrived, and it was really, in my opinion, giving very inaccurate information. So in some cases, I think that the oximeter was actually prompting unnecessary transfusions, which was a real problem. So we brought the CASMED system in, and we instituted our program. And as you can see, moving forward, we had a pretty significant reduction in blood utilization from almost 2 units to down to less than half a unit per case, per patient. And we've been able to maintain this low level of blood utilization since that time. And it results obviously in a significant cost savings to the hospital, but more importantly, it improved our outcomes. And as we improve the outcomes, and the outcomes I'm referring to are the things that our Society of Thoracic Surgeons track to create each program's quality rating, and that includes stroke rate. So the really neat thing about this was we decreased our blood utilization, but our stroke rate did not change. It did not go up. So we used a significantly smaller amount of blood in patients and didn't cause more brain injury. So this is a graph showing the various complications that we track: strokes, renal failure, wound infections, reoperations, length of stay. And basically all of these variables of complications that we track improved as blood utilization decreased. And that's consistent with what all the data in the literature shows, that if you can get people safely through heart surgery without giving them transfusions or reduce the blood administration, their outcomes are going to improve. This is a picture of the abstract I presented at the ASA detailing this project. And it worked very well. And it's something that I think the oximeter can play a role in and can be helpful. Yeah. Anyway, so to wrap up, some important points about oximetry and an accurate oximeter are that I think the technology is at a point where it's useful in clinical practice. And if you're going to use an oximeter, you should try to use one that has the best accuracy, because managing the desaturations is really hinges on believing that they're occurring. And I think the CASMED device, the Foresight Elite, so far the ones that I've used works very well. And if you don't use oximetry, for those of you in the audience that don't use oximetry, I'll put a plug in to consider doing it, because if you're not using oximetry, you're not even aware that the problems are occurring. And for those of you that are using other oximeters and you find that they don't correlate with what's happening from a clinical standpoint, you should consider changing to one that has more accuracy, because if you're getting false information, you're going to do things like we were doing, which is giving blood unnecessarily, for example. And so the cost of inaccuracy can sometimes be worse than not using it at all. And just to review that the CASMED device, for those of you that are not familiar with it, provides a high level of precision, because it's using 5 wavelengths of light to deal with all the confounders that are present in cerebral oximetry, and there are multiple. And if you don't adequately deal with the confounders, and those would be things like scalp blood flow, the effects of the bone in the head, and so on, then the information the device gives you is going to not make sense. So again, I think relative to oximetry and using it clinically, the CASMED system is really one of the best. So to summarize then, what do we know? We know that our patients every day are getting older and have more problems. And that's just the reality we're going to be facing in cardiac surgery. We also know that in any given patient, it's very hard to know what their lower limit of cerebral autoregulation is. In other words, what that magic blood pressure is, above which the brain's going to be happy, but below which you're going to be potentially making the brain ischemic. And the study I reviewed by Charlie Hogue just points out the high level of variability in that issue. Well, I don't know about your institution, but at our institution, full montage EEG is reserved only for circulatory arrest cases. And if you do that, you're going to need to have a neurologist around to read it real time. And because I don't know of many cardiac anesthesiologists that are good, myself included, at reading a diagnostic EEG. Or use transcranial Doppler, because these are the only real 2 other ways to know that the brain's not ischemic. And they're really, from a clinician standpoint, not in an academic place with a lot of support, not very practical. We know that a multimodal approach, as described, doing all the things we talked about, can significantly improve patients' neurologic function after surgery. And finally, that given the currently available tools that we have, that cerebral oximetry even given its limitations, is really the only non-invasive tool that we have currently to assess adequacy of cerebral oxygen delivery, and that's why we use it. So that concludes the talk. Bolshoi spasibo, and if you have any other questions, you can address those now.
Professor Brooker,
Yes.
listen me. Thank you very much for nice presentations, very helpful, without doubt. One question: what's your opinion or experience of using tissue oximetry for measurement of mesenteric oxygenation?
Well, I think those are all useful tools. We will use those in various clinical situations. For example, on patients that having going on ECMO, where you're putting large cannulas into the femoral artery and femoral vein, we'll put a tissue oximeter on that leg compared to the other leg, and use that as a way to know we're not making that limb ischemic. So I think they're very useful to answer your question in a similar way that the oximetry in the brain is. On our pediatric patients having cardiac surgery, we will use a abdominal oximetric pad and follow those numbers as well. So in the standard adult cardiac patient, we use the brain as an index organ, and our assumption is barring any big cannulas in the groin or things like that, and if the brain is getting adequate oxygen delivery, then it's likely the gut and the extremities are as well. But we will put tissue oximeters on any location where we think there's a potential for inadequate oxygen delivery. So it's a great question.
May I ask you a question?
Sure.
Oh, Dr. Helwig, my congratulations for your excellent presentation. And please tell me, what percentage of ischemic stroke and hemorrhagic stroke do you have in your clinic?
Thank you for the question. Our current stroke rate for standard cardiac surgery in adults is about 1.5%. And that, by stroke, we're talking about a lesion that is fairly easily identified. So, which I think is the benchmark most private practice institutions do. So we do not, so in other words, we don't have a neurologist go around and do neurocognitive testing on our patients after surgery, but we do a complete neurologic assessment. And if there's a noticeable deficit, then we qualify that as a stroke. And using our current approach, we're less than 2% for standard cardiac surgery. For complex aortic arch replacement and procedures with circulatory arrest, actually we're getting ready to publish our series on that over the last 5 years, but our stroke rate is pretty low. It's between 5 and 6%, which compares pretty favorably in the United States. The published rates for circulatory arrest and complex aortic work is significantly higher than that. So that's where we stand with those.
And please tell me, should we use oximetry in patient with ischemic or hemorrhagic stroke?
Well, I think if it's a hemorrhagic stroke, the oximetry, well, In either case, the oximeter can potentially provide good information. Hopefully, there aren't a lot of situations where you're bringing a patient for cardiac surgery that has an active hemorrhagic stroke. That would not be a good situation, but potentially that might occur. If somebody has a high-grade left main and unstable angina, is in cardiogenic shock, and they have a brain bleed, they may need something done. So the way I would look at that is it's better to know that the surrounding brain is getting adequate oxygen delivery than not. And then if the saturation is unilaterally dropping, for example, during the operation, that would prompt you to immediately get a CT at the end, and then that patient may need to have decompression or some type of neurologic surgery concurrent with the heart operation. So I would say in either of those situations, the oximeter can provide helpful information about what's going on with the brain in the penumbral or the surrounding areas that could be useful to you. Remember that in the big scheme of things, unfortunately, in cardiac surgery, probably the largest source of neurologic injury is going to be embolic. And the embolic delivery of injury to the brain is really can occur in all different areas of the brain while you're monitoring it with oximetry. So unless you have an emboli be delivered to the exact spot that the oximeter is measuring, it may not tell you that a focal embolic event has occurred. So the oximeter's really, its utility is going to be that globally the brain is getting adequate oxygen delivery. So if you really want to focus on reducing neurologic injury, you've got to employ the multimodal program and do everything you can do to minimize the embolic risk. And that means teaching the surgeons how to use a handheld ultrasound probe to scan the ascending aorta, which interestingly they pick up very quickly. That way you can pick the spot that you're going to put a clamp on or put the arterial inflow cannula in, and you can minimize the chances of the emboli being delivered to the brain. But in addition to that, again, you want to know on a routine basis that when you go on pump, that the mean arterial pressure you're allowing to occur and the pump flow rate you're creating is adequate for global oxygen delivery to the brain. And the oximeter can directly speak to that.
Thank you.
Excellent questions.
Excuse me. And did you use system for multi-modal nerve monitoring like ISM Plus by Chosnica from Cambridge or Mosaic from San Francisco?
Well, as I mentioned in the presentation, for our routine cardiac surgical cases, every case gets a TE, so has echocardiography interoperatively. Every case gets epiaortic scanning. Every case has cerebral oximetry monitoring. Now, that's for routine cardiac cases. If we're going to do complex aortic work, or there is a chance for circulatory arrest, then I'm moving off the screen, sorry. Then we will add 16-channel EEG monitoring to that. So that's our current array of things we will use, and expanding the monitoring to include the EEG really hinges on whether we think we're going to do a circulatory arrest.
Thank you very much.
Yep. Excellent question.
So I think thank you very much, Dr. Brooker. Everything worked perfect.
Well, thank you very much, Nadia, and большое спасибо. And thanks for your attention.
Thank you.
До свидания.
Thank you.
I'm frozen.
Right?
All right. Thank you, Dr. Brooker. Thank you, Patrick.